Welcome to this deep dive. We're focusing today on anesthesia concepts, specifically tailored for surgical residents heading towards board exams, like the FRCS in plastic surgery.
That's right. We want to really boil down the essentials of general anesthesia, regional techniques, and sedation that you absolutely need to know for those exams.
Okay, good. So where should we start? General anesthesia.
Let's do it. The main goals here are pretty clear.
Yeah.
Amnesia, so the patient doesn't remember. Analgesia for pain control. Muscle relaxation, which is vital for surgery. And importantly, controlling the sympathetic stress response.
Right, preventing those big swings in heart rate and blood pressure. But before all that, the preoperative evaluation is critical.
Absolutely critical. You're asking two main things. Is the patient as healthy as they can be right now? And is there anything we can do to improve their condition before surgery?
Which brings us to the ASA classification.
Yes, the American Society of Anesthesiologists Physical Status Classification, it's fundamental. Goes from Class 1, a completely healthy patient, up to Class 5, someone who's moribund, unlikely to survive without the surgery.
And Class 6 for organ donors, plus the E for emergency cases.
Exactly. And this isn't just academic, it strongly correlates with outcomes. Knowing someone is, say, an ASA 3 flags up potential issues you need to manage carefully, like maybe closer BP monitoring or specific drug choices.
Makes sense. What about pre-op labs? Do we need a full panel on everyone?
Generally, no. Not for healthy ASA 1 or 2 patients having fairly minor procedures. But pre-medication, that's often key.
To get the patient relaxed and cooperative.
Precisely. We use different drug classes. Anxiolytics, usually benzodiazepines for anxiety, maybe anticholinergics like scopolamine or atropine to dry up secretions.
Analgesics too, paracetamol, NSAIDs, maybe even opioids.
Yes, to get ahead of the pain. And antiemetics are important too, things like ondansetron, to prevent post-op nausea and vomiting, PONV.
Okay, so the patient's prepped. Now intraoperatively, induction.
Right, getting anesthesia started. Usually it's with IV agents.
Yep.
These are rapid-acting hypnotics like propofol, etomidate, thiopental, or ketamine.
Propofol's very common.
Extremely common. But what if you're worried about aspiration? A full stomach, for instance.
That's where rapid sequence induction, RSI, comes in.
Exactly.
Yeah.
It's a specific technique. Give the IV induction agent, then immediately a fast-acting muscle relaxant, usually succinylcholine or high-dose rocuronium, and apply cricoid pressure, the Selleck maneuver.
To prevent stomach contents coming up?
Correct. Though cricoid pressure itself is a bit debated now, the principle of rapid control is key. For kids, though, we often prefer an inhalation induction.
Breathing the gas down.
Yes, typically with sevoflurane because it doesn't irritate the airway as much.
Okay, induced. How do we maintain anesthesia?
Two main ways. Inhalational maintenance using gases like nitrous oxide or the volatile agents sevoflurane, diflurane, isoflurane, or intravenous maintenance, usually a continuous propofol infusion.
You mentioned the volatile agents have limited analgesic effect.
That's a really important point. They provide the hypnosis, the unconsciousness, but not much pain relief. And there's a potential, though rare risk, of liver issues post-op, especially with older agents like halothane, which we barely use now.
So you need other things, like muscle relaxants.
Often, yes. Neuromuscular blockers, the NMEs, depolarizing like succinylcholine or non-depolarizing like rocuronium or vecuronium. They allow for lower doses of the main anesthetic agent.
But there's a risk there too, awareness.
Yes, if the anesthetic depth isn't adequate while the patient is paralyzed, they could be aware. It's rare, but devastating. We also use opioids frequently to blunt those sympathetic responses to surgical stimulation.
Got it. Let's look a bit closer at those inhaled agents. Nitrous oxide.
It has some analgesic properties, which is useful, but a big drawback is it can expand into air-filled spaces like pneumothorax, bowel obstruction. Bad news there.
Okay. Isoflurane.
Quite pungent, so not great for mass conduction. And it can dilate coronary arteries. There's a theoretical risk of coronary steal in patients with coronary artery disease, though the clinical significance is debated.
Dysflurane.
The most pungent, really high risk of laryngospasm if you try a mass conduction. But it wears off very quickly because it's not very soluble in fat. Good for rapid wake-ups.
Downsides.
It can cause sympathetic stimulation, increase heart rate and blood pressure, especially if the concentration is increased rapidly.
And sevoflurane.
Much nicer profile for induction. Sweet smell, non-pungent. Definitely the go-to for mass conductions. It's also a good bronchodilator.
Okay, moving to the muscle relaxants, the NMBs. Succinylcholine.
The classic depolarizing agent. Super fast onset, very short duration, because it's broken down quickly by plasma cholinesterase.
Causes fasciculations, those muscle twitches.
Often does, yes. And the critical thing to remember, It's a major trigger for malignant hyperthermia, especially when used with volatile agents.
Given it works so fast, why not use it all the time?
Well, the MH risk is one thing. Also, the fasciculations can cause muscle pain post-op. And there are contraindications like burns, crush injuries, certain nerve disorders where it can cause dangerous potassium release.
Right. What about the non-depolarizing agents? Vecuronium, rocuronium?
Vecuronium is cleared by the liver and kidneys, pretty clean cardiovascular profile. Rocuronium has a faster onset, almost as fast as succinylcholine at high doses, making it an alternative for RSI. Similar clearance, also clean cardiovascularly.
And atracurium or cisatracurium?
Their big advantage is Hoffman degradation. They break down spontaneously in the plasma, independent of liver or kidney function. So they're great choices if you have a patient with organ failure.
And just to hammer it home, malignant hyperthermia triggers.
Succinylcholine and all the volatile anesthetic agents, isoflurane, sevoflurane, deutzlurane, not nitrous oxide though.
Good clarification. Okay, let's pivot to regional anesthesia.
Sure, this covers everything from simple local infiltration at the surgical site to peripheral nerve blocks targeting specific nerves or plexuses, up to central neuraxial blocks like spinals and epidurals.
It all relies on local anesthetics. How do they actually work?
They block sodium channels inside the nerve axon. To get inside, they need to cross the nerve membrane, and they do that best in their unionized lipid-soluble form.
Ah, so the PCOS matters.
Hugely. The PICO tells you the pH at which half the drug is ionized and half is unionized. A drug with a pCal closer to the body's physiological pH, around 7.4, will have more unionized drug available at that pH.
Meaning a faster onset.
Exactly. Lidocaine, for example, has a pCal around 7.9, so it works relatively quickly. Bupivacaine's pCal is higher, around 8.1, so it takes a bit longer to set up.
Yeah.
Understanding this helps you choose the right drug when time is critical, like for a quick procedure.
And different nerve fibers get blocked at different rates.
Yes. Smaller fibers and myelinated fibers are generally more sensitive. Typically, you lose pain and temperature sensation first, then touch, pressure, and finally motor function. Recovery happens in the reverse order.
Okay. Classification of local anesthetics.
Two main groups based on the chemical link: esters and amides. Esters like procaine, tetracaine, cocaine are metabolized by plasma pseudocholinesterase, short half-life.
And they produce PABA, para-aminobenzoic acid?
Yes, which is the breakdown product responsible for most true allergic reactions to local anesthetics, although these are rare.
Okay, and the amides?
Amides, lidocaine, bupivacaine, ropivacaine, mepivacaine, prelocaine are metabolized in the liver, longer half-life. True allergy is extremely rare, but sometimes patients react to preservatives like methylparaben, which is structurally similar to PABA.
Easy way to remember them.
The mnemonic usually taught is that amides have an I in their name before the valproic. Lidocaine, bupivacaine, ropivacaine.
Useful. Any specific properties? You mentioned bupivacaine's onset.
Bupivacaine is very long-acting, great for post-op pain, but it has a higher risk of cardiotoxicity compared to others. Ropivacaine is similar, maybe slightly less cardiotoxic. Lidocaine is the workhorse, intermediate duration. Prelocaine carries a risk of methemoglobinemia, especially in higher doses.
And there's a newer formulation, liposomal bupivacaine.
Yes, Exparel. It's bupivacaine encapsulated in liposomes, designed for slow release. It can provide analgesia for up to 72 hours, which is great for reducing opioid needs post-surgery.
Important considerations.
You need to be careful not to administer other local anesthetics for a while after using it, and some skin preps can interfere with it. Read the instructions carefully.
Can we add things to local anesthetics?
Yes, several additives are used. Opioids like fentanyl or morphine can be added for spinal or epidural anesthesia to improve pain relief. Morphine can cause delayed respiratory depression, though, hours later.
What else?
Clonidine, an alpha-2 agonist, can prolong the block and add some analgesia, but watch for sedation and low blood pressure, and sodium bicarbonate.
Why add bicarb?
It raises the pH of the local anesthetic solution slightly. This increases the proportion of the unionized form, speeding up the onset of the block.
Works for all of them.
Generally, yes, but you have to be careful. With bupivacaine and ropivacaine, adding too much bicarb can cause them to precipitate out of solution. There are specific recipes.
And the most common additive, epinephrine.
Absolutely. Usually concentrations like 1.100,000 or 1.200,000. It works by causing vasoconstriction.
Which does what?
Several things. It reduces blood flow, so the local anesthetic stays in the area longer, increasing the duration of the block. It also reduces systemic absorption, lowering toxicity risk and reduces bleeding at the site. Some say it might even speed onset slightly by itself.
Sounds great. Any downsides?
Oh yes, systemic absorption of epinephrine can cause tachycardia, hypertension, palpitations, anxiety, so you need caution in patients with significant cardiovascular disease. Remember, the red labels on vials containing epinephrine, always double check.
Are there places you absolutely shouldn't use it?
The classic teaching is avoid it in end arterial areas, fingers, toes, nose, penis, earlobes, due to risk of ischemic necrosis. However,
There's nuance there.
yes, a lot of evidence now supports the safe use of dilute epinephrine, like 1.200,000 or even 1.400,000, in digital blocks for hand surgery, provided you inject carefully, avoid circumferential blocks, don't use huge volumes, and the patient doesn't have severe vascular disease. It improves the surgical field significantly. But absolute contraindications remain things like poorly perfused flaps or maybe severe Raynaud's.
Okay. What about mixing different local anesthetics, like lidocaine for speed and bupivacaine for duration?
People do it, but it's generally discouraged. The effects on onset, duration, and potency aren't always predictable. Plus, it increases the chance of drug errors and toxicity is additive. Usually better to pick one agent and use the right concentration and volume.
Makes sense. Let's talk toxicity.
Okay, systemic toxicity happens when too much drug gets absorbed into the bloodstream. Risk depends on the dose. The site of injection, more vascular sites mean faster absorption, and whether you used epinephrine.
Allergy is rare, you said.
True allergy is very rare, mostly with esters due to payback. Contact dermatitis can happen, sometimes with lidocaine patches, and again, watch out for methylparaben preservative allergy.
What about systemic toxicity symptoms?
It usually affects the CNS first, then the cardiovascular system. CNS effects are dose-dependent. Maybe numbness around the mouth, tinnitus, lightheadedness, then visual disturbances, muscle twitching, confusion, eventually seizures, coma, respiratory arrest.
Scary. And the heart?
Cardiovascular toxicity typically requires higher blood levels. You might see bradycardia, hypotension, arrhythmias, heart block, and potentially cardiovascular collapse. Bupivacaine is particularly notorious for being cardiotoxic and difficult to resuscitate from.
Why bupivacaine?
It binds very tightly to cardiac sodium channels.
Anything else? Hematologic?
Yes, methemoglobinemia, mainly associated with prelocaine and sometimes benzocaine topical sprays. The iron in hemoglobin gets oxidized, can't carry oxygen effectively. Patients look cyanotic but have normal oxygen saturation readings.
How do you treat toxicity?
Prevention first. Calculate maximum safe doses. Always aspirate before injecting to check for blood return. Inject slowly. Use incremental doses. If toxicity occurs, stop injecting immediately. Call for help. Manage the airway oxygen, maybe intubation. Control seizures with benzodiazepines. Basic and advanced life support if needed.
And the specific antidote?
Intravenous lipid emulsion therapy, or intralipid. It acts like a lipid sink, pulling the lipid-soluble local anesthetic out of the tissues and plasma. It's become standard treatment for severe systemic toxicity, especially cardiotoxicity.
Good to know. Okay, specific regional techniques. Local infiltration.
Just injecting into the tissues you're working on. To make it less painful, use a small needle. Inject slowly, warm the solution, and consider buffering with bicarbonate again. Careful with bupivacaine or epipene. Injecting superficially into the dermis hurts more but works faster.
Effective in infected tissue.
Less so. The acidic environment of infected tissue means more of the local anesthetic stays in the ionized form, which can't cross the nerve membrane as easily. You often need larger volumes or different techniques.
Peripheral nerve blocks.
Targeting specific nerves. Ultrasound guidance has revolutionized this, making it safer and more effective. You need to consider patient factors like anticoagulation or pre-existing neuropathy. Catheters can be placed for continuous blocks.
Beer block. Intravenous regional anesthesia.
That's where you exsanguinate an arm or leg, put up a double tourniquet, and inject dilute local anesthetic, usually lidocaine or prelocaine, into a vein. It anesthetizes the whole limb below the tourniquet.
Key safety point.
The tourniquet must stay inflated for a minimum period, usually at least 20 minutes, but often recommended 40 minutes, even if the surgery finishes early. Deflating it too soon risks a sudden bolus of local anesthetic hitting the systemic circulation toxicity. And you need to monitor the tourniquet to ensure it doesn't fail.
Central neuraxial blocks, spinal and epidural.
Right. Epidural involves placing a catheter into the epidural space outside the dura mater. Spinal means injecting directly into the cerebrospinal fluid, the CSF, in the subarachnoid space, usually in the lumbar region.
Advantages of epidural.
More flexibility in the level of the block. You can achieve a segmental block, affecting only certain dermatomes, and the catheter allows for continuous infusion or top-ups for prolonged surgery or post-op pain relief.
And spinal.
Much smaller dose of local anesthetic needed, usually a faster onset and denser block. The spread depends on factors like the dose, volume, patient position, and the boricity of the solution.
You mentioned boricity earlier. Can you quickly recap that?
Sure. Boricity is just the density of the local anesthetic solution relative to the CSF. Hyperbaric solutions are denser than CSF, so they tend to sink. If the patient is sitting up, the block will concentrate lower down. Hypobaric are less dense, they float. Isobaric have the same density, spread is less affected by gravity.
Complications of spinal epidural.
Post-dural puncture headache, PDPH, is common after spinal, less so after epidural, unless the jaw is accidentally punctured.
Oh.
Caused by CSF leakage. Treatment is rest, fluids, caffeine, analgesics, sometimes an epidural blood patch.
Other risks.
A high spinal, or total spinal, where the block goes too high, causing profound hypotension, bradycardia, and respiratory arrest, needs immediate airway and circulatory support. Epidural hematoma is rare but serious, needs urgent MRI and surgical decompression. Hypotension due to sympathetic blockade is common. Urinary retention, too.
Okay. Briefly, topical anesthetics.
Applied to skin or mucous membranes. Ideal ones work fast, are easy to put on and take off, don't stain, aren't toxic, don't need occlusion, and provide good anesthesia with minimal systemic absorption. Things like ELA cream, lidocaine patches, LAT solution. There are tables listing specific agents and their uses.
Got it. Final area. Sedation and analgesia, or conscious sedation.
This is a drug-induced depression of consciousness where the patient can still purposefully respond to verbal commands or light touch.
Yep.
Importantly, they maintain their own airway and protective reflexes.
How are drugs given?
Usually titrated in small increments to achieve the desired effect. Continuous infusions might be better than repeated boluses sometimes, giving smoother levels.
What are the goals?
Facilitate the procedure, obviously. Control anxiety and behavior, especially in kids or anxious adults, and ensure the patient can be safely discharged afterwards.
Who is a good candidate?
Generally healthy patients, ASA class I or II, are suitable for sedation in settings like an office or ER. ASA 3 or 5 patients need a more controlled environment and often anesthesia personnel present.
Documentation and monitoring are key here, I imagine.
Absolutely. Consent, fasting status check, medical history, vital signs before, during, and after. You need to document all meds given, the route, doses, and who was present.
Personnel.
At least 2 people. One performing the procedure, who might also administer the drugs, and another person solely responsible for monitoring the patient, usually a nurse. Specific protocols exist for ER settings.
What monitoring is needed?
Standard is oxygen saturation, pulse oximetry, heart rate, blood pressure. Capnography, measuring end-tidal CO2, is highly recommended now, as it gives real-time info on ventilation respiratory rate and pattern. Vital signs need frequent documentation.
And the absolute necessity for success.
Patient cooperation and the ability to remain still for the procedure.
Okay, let's quickly recap some high-yield points for exam prep.
Good idea. Remember, disfluorane's pungency making mask induction tricky. Ester local anesthetic allergy linked to PABA. Metylparaben preservative allergy is possible with amides.
Low-dose epinephrine in digits generally safe with precautions. Liposomal bupivacaine for long-lasting analgesia.
Keep talking to the patient during monitored anesthesia care, sedation. Be aware of synergistic effects when combining sedative drugs. And capnography is really valuable for monitoring ventilation during sedation.
Excellent summary. That wraps up our focus review of these core anesthesia principles.
Hopefully this serves as a solid foundation or refresher as you prepare for your surgical board exams.
Definitely. We encourage you to keep thinking about how these fundamentals apply across different surgical situations and patient types you encounter. Thanks for joining this deep dive.